Thank you. Thanks, Erica, for the introduction. And very thrilled to be here today, talk to you about some of the work that we do in the center. As you can imagine, this topic is really hot and in a lot of ways emerging. So what I tried to do for you today is just to give you really a snapshot of what we know works for obesity treatment and how it can be delivered through, technology, focusing specifically on mobile technologies. But clearly, this literature is really vast. So if you have any questions, I really want this to be highly interactive. I know we have a lot of students here, and I'm going to try to show you a couple applications that we've done, certainly domestically, where most of our work is focused on adults in the U.S. But I want to show you a couple applications of how this can be applied globally. But again, if you have any questions, please ask throughout. Don't hesitate. And I hope you're enjoying your pizza and soda at this obesity talk. Yeah, well, apparently pizza is more exciting than salad, right? Yes, it is. So let me just start by getting us all on the same page here with the stats around obesity. But I should ask, are people familiar with obesity as being a public health problem, a very challenging one? So yeah, I'll show you a little bit about what we know here and also globally. So about a third of the U.S. is obese, and when I say obese, I mean we use the indicator of body mass index, which is body mass of 30 or above. So to kind of help you understand what that actually means, the average woman's about 5'4", and so if she weighed 180 pounds or more, she'd be considered obese. So anything below that, the 135, 140 to 180 is sort of overweight, and anything below that, is normal or underweight. Just to give you a sense of that. So about a third of women right here are obese, and about a third of men are. And what is very disturbing is that now we're almost seeing almost a third, or 26% of children are considered obese. So clearly, a lot of need there for how we can figure out to deal with that. I said our work focuses mostly on adults, but we're actually thinking about ways we can branch out. More recently, talking with a group that does a lot of childhood obesity treatment and how we can work with parents and how that can trickle down to children. So clearly, there's a need there as well. But what's really interesting is that you might have heard, okay, it's doubled or tripled over the past few decades, but it's even increased, from not that long ago. So it's still on the rise. And the consequences are certainly widespread. So highly linked to heart disease, diabetes, cancers, and the costs in both quality of life and the medical costs associated with those chronic diseases are certainly a problem as well. And you might not know this, but just recently, and I think the last year or two, obesity is now considered a disease, recognized as a disease. And there's a whole host of things that happen as a result of that. But it took a little bit of a long time to get us to that place. So here's just a snapshot globally, so you can see the countries in red, and rates globally have also doubled since 1980 or so. So the snapshot of the countries in red those are comparable to what we're seeing in the U.S., although some are a lot higher than 30%. But you can see, the U.S. is certainly a big driver here, but there are other countries that also have really high rates as well. But what I think is really interesting, looking at this globally, is that we see that 65% of the world's population live in countries where overweight and obesity kills more people than underweight. So there's definitely there's a dual burden of disease going on here, but certainly it's a lot more widespread than you might have thought. And here again is just another way of showing you that it's increased over the past 20 years when we look at this on a global scale. This is just a snapshot of just a few countries, and you can see the steepest line really, I don't know exactly, but is really the U.S. So the U.S. is driving our global rates, but it's happening elsewhere. So let's take just a second to see who is most affected by obesity in the U.S., because this has driven a lot of the work that we've done in our group. It's not just, a third of the U.S. is obese, but who really is most affected? And if you look at women on the right here, this is data from the Pew Research Center, and you actually see me presenting a lot of their data, and if you haven't checked them out, I highly recommend you do, because they have some really interesting data that you can look at. So with women, we see, so just to orient you, this is looking at gender, race, ethnicity, and income. And so the darkest brown here is high income, and then the lightest color here is low income. And you can see across all racial ethnic groups, we're seeing that there's this gradient, that the lower income has higher obesity rates than the higher income. Of course, what's really most interesting, and particularly to us, is that there's still this gradient when we look at black women, but that the rates are so much higher. So, half of all black women in the U.S. are obese. And so there's certainly indicating a need there in this population. And I'll show you one study today where we use mobile technologies with this group, but we've done a lot of studies, in this group who's clearly has need, but also unfortunately is under-researched. With men, we see a different story. We see that there isn't the same gradient necessarily when it comes to income, and that there are differences by racial ethnic groups, so that's not that low income has higher obesity than high income. Actually, in black men in particular, higher income is more likely to be obese than lower income. So a totally different story. And we could probably have an entire talk or discussion just on sort of the determinants of this, or reasons why. It's very complex and multifactorial, but wanted to give you a sense just how this picture looks and who really is in the most need of obesity treatment. Any questions on that? Okay, so what works best for obesity treatment? Let me ask you first, just curious what you think. So what do you think is the best way to treat obesity? Diet? Okay, yeah. Lifestyle, got the key lingo here, okay.
Community involvement has been shown to increase it quite a bit. If they can get involved with the community, that's supportive.
Definitely, you got touching on social support aspect, definitely.
Weight loss approach. Taxing foods that are unhealthy.
Oh, so you're getting into the policy space, okay. Yeah.
Also medication, if obesity is related to diabetes or some other sort of incidents.
Yes, definitely. So are you thinking obesity medications or diabetes medications?
So things that are cooperative. So like Maripex, I think, treats diabetes, but also reduces the obesity level to a large degree with some people.
Right.
So the ones that work together. So I'm thinking more treating the disease that relates to obesity.
Yep. And then, conversely, you can think about the opposite as well. If you treat the obesity, whether with pharmacologic or lifestyle, or which you're touching on a lot. So certainly, I'm asking because it's incredibly multifactorial, and there are a lot of different ways we can get at trying to treat obesity or prevent obesity. And so, what I'm going to talk about today is really kind of giving you a sense of this individual-based approach to obesity treatment in adults, right? But I want to just the caveat that we could, if we just tax, potentially that would have a larger impact on a larger amount of people. And that's a different approach to think about how we can treat it. And I think that they should be happening concurrently. So let me just kind of quickly run through bullets of what we call a standard behavioral approach to weight control and thinking about adult obesity. So you have obese adults, we're trying to get them to lose weight. So I heard about lifestyle changes, you hit that right in the head. Teaching them what works, the behaviors they need to do, things like how to control your portions or how to incorporate more activity into your lifestyle. I mean, kind of things that you might be doing or aware of, but there's this sort of standard approach with these evidence-based, strategies that we teach people. Counseling face-to-face is a huge component of this approach and highly effective. People are given calorie goals that they have to achieve, intensive ones, get down to 1,300 calories a day and you'll see weight loss. Exercise up to 200 minutes a week or 300 minutes a week to see weight loss. Even the use of meal replacements, which might be controversial, but certainly they work if people stick to them. If you have Slim Fast or Lean Cuisine or whatever. But one of the key things of this, and the cornerstone, as we say, of behavioral weight control is self-monitoring. So having people keep track of diet, exercise, weight, generally to just increase their awareness and have a greater understanding of what they're actually eating and how much they're actually exercising. But this approach is fairly intensive. I've actually worked for years doing this in both the research setting and outside, in sort of the private sector in that regard, doing private practice. But it works. But the question is whether at what cost. So this approach is fairly costly and also requires a lot of effort on both the provider and the participant, or the patient, however you want to call them. They have to come in to see someone face to face. They have to keep track of everything they're eating. And so it's an intensive approach. And I want to introduce you to the word intensity because I'll talk a lot about it and how we could maybe leverage technologies to reduce the intensity but still be effective. Okay, so after what we know from the literature, gold standard trials, a lot of trials, after 6 to 12 months, people lose about 7 to 10% of initial body weight. So if you weigh 200 pounds, that's about 15 to 20 pounds. With all that. So let me ask you, do you think that's enough to really see a clinical benefit? Yeah?
Probably, to some degree.
Mm-hmm. Anyone think no? Thank you. So we actually It might not seem like a lot, because if you weigh 200 pounds, you might want to weigh 150, right? You want to weigh 140, you want to get down out of the BMI of 30 or above and get down. But truth is that we know with even as little as 5% weight losses, so a 10-pound weight loss, if you started at 200, can have clinical benefits. Even 3%, just recent guidelines came out this year. All you have to do is lose 3%, and you'll see some clinical benefit. Now, if you lose more, will you see more benefit? That's actually, I think, true. A little. I'm not sure if we know that for sure, but it doesn't take large weight losses to have a benefit on your health. And when I say benefit, I mean showing improvements in things like blood pressure, glucose, cholesterol, triglycerides, and whatnot, those risk factors for the chronic disease. So I know I'm giving a lot of background here, but I think it's important. So here is I'm going to talk you quickly through what was called the Diabetes Prevention Program, which is a seminal study that showed that this lifestyle approach can be really effective, not only helping people lose weight, but also in reducing incidence of chronic disease. So in this case, they took about 3,000 people across the US who were pre-diabetic. So they didn't have it yet. And if they tested, if they gave them a lifestyle approach or they gave them metformin, which is the pharmacological treatment of diabetes, which could be more likely to prevent the onset of diabetes. And as you can see here, the lifestyle group, those receiving this lifestyle approach, they had a much higher, lower reduction in the incidence of diabetes than those just getting the meds. And this is because they actually lost weight. They lost about 7% of the body weight. But the question is, do you think that these people kept it off? So here, I'm going to show you that unfortunately, I mean, this was a large trial, across the U.S., NIH funded, like very, and it had a place because it showed us that if you tell people to lose, if you get people to lose weight through lifestyle, you can prevent onset rather than just going towards drugs. And that's really, really important. And this study is, again, used all the time. It's translated to different population settings, even globally, so it's clearly effective. But the question is whether this approach allows it to be sustainable in the long term. So the great thing about this study is that they had 10 years of follow-up on these people. And you can see that they, by the time you get to year 5 or so, they're not that different from metformin, and it's questionable as they get out if it's that different from placebo. I will tell you, though, that even at 10 years, they're seeing lower incidence of diabetes, though, interestingly, among the group, and other clinical benefits. But, I mean, I'm showing you this because I want to, you to recognize that these approaches are really effective, particularly in the short term, but it's questionable whether or not these approaches are sustainable in terms of weight loss, years and years later. And we think that, if we could use other technologies, they have a greater potential to be something that can be sustainable, right? You don't have to have someone come in to see you face to face. You don't have to get them to take meal replacements or do all the intensive approaches. Okay, so like I mentioned, the cornerstone here is self-monitoring. So here's a classic paper-based self-monitoring diary. Is anyone willing to share if they've used this approach personally? Whether to change your diet or to lose weight or anything, just to be more aware. Anyone done that before? Okay. How was it for you, if you don't mind sharing?
Well, it was a pain in the ass back in the paper days. Oh, sorry.
We're being recorded,
but I'm sure you're headed this way. Usually it's a lot different.
Yeah. But you brought up a good point. So you said it was a pain. Is that because, what was it? Can you elaborate on that?
It's just, I would say, the time to write, to take a pen,
right.
To track. It's the same with some people that use tracking for gym activity. If you work with a trainer, that sort of thing, you have to write everything down.
Right. It takes a lot of effort. So how long did you get stuck with it? Can you guess?
No, I don't remember with a paper system like this.
Yeah. Most people, and research says it's a little different, but a lot of people tell me they can only go a week and then they're done. It's not an easy thing. And that's because you need a lot of tools. So you need the classic approach and is this book you carry with you all the time. So it's pocket size, but you have to look up everything, and then you have to have a big calculator to do all the math here required to look up, like you can see, it's not just the food, but it's the portion, it's the calories, it's the fat, it's these details that really help you understand how much you're actually taking in. It's questionable whether you need this detail, but this is what the approach suggests. And then, something like a pedometer. So, these are, yes, they're old school tools that people use, but and they work if people can stick with it. And that's the problem, is that we see this trajectory over time. Sorry, you can't see the month there, but people start out strong and then it goes down fairly quickly, and then by the end of an intervention, it's about a year, you get about 25-30% of people doing this and not much more. those people are losing weight and keeping it off, but it's the other people, 70% that we want to deal with. So our challenge is to get it to go from here to something like this, right? So that it's more stable and more consistent. And actually, a study that just came out was looking at whether, do you actually need the level of detail like I just showed you on the previous page? Does it have to be accurate? Do you really have to know how many calories are in an apple or a bagel or whatever? And the question is, actually the answer is that you don't. You just need to be consistent with it. You have to keep doing this. You can't stop doing it. So that, kind of relieves some burden, I should say, about, the fact that that usually is associated with this behavior. But again, this is our challenge, but there's an opportunity here to be able to use mobile devices to help make it easier to self-monitor, which you started to get into a little bit, is that, maybe we have these devices that can make it easier, that you don't have to go through all the burdens associated with it. But let's talk a little bit about how many people actually this could work for. So I know the answer already, but raise your hands if you have a cell phone. Okay, pretty close to 100%. So comparable to what we're seeing in the US, that 90% of US adults have a cell phone. Again, this is the Pew Research Center data, check it out. How many people have a smartphone? All right, so it's pretty high. How many people have the new iPhone 6? You got one. All right, we got one. That's okay. You don't have to have that. But I don't have one. 58% of U.S. adults have a smartphone. And what's really interesting, particularly with the cell phone, is that this is not just for people who are resourced. And we've been seeing this more with the smartphones. Right? Of course, every year we get more and more people have it. Is that this crosses all racial ethnic groups and income levels. And in fact, when you think about mobile access to the internet, or internet access, for example, when you think about mobile access, or racial ethnic minority groups are more likely to have mobile internet access than, say, having a computer. So, the idea back in the early 2000s of the digital divide is no longer something that's an issue. This is really ubiquitous, and I'll show you, as you might already know, how it's ubiquitous on a global scale as well. So, what do you think most people are using in the US? And this actually applies globally too, but what do you think most people use their cell phone for?
Text messaging.
Text messaging, yep. Text messaging is number one thing, and only about a third of people actually use it to, say, look for health information. They're mostly using it for text messaging. So you can see where I'm going here is that, yes, we have all these apps and things like that, but that if we're, we could really reach a lot of people with maybe just text messaging. But there are, 1,000 or more apps of diet and fitness in the App Store, and I'll talk a little bit about them, which we actually don't know that much about in terms of evidence for. And who's heard of MyFitnessPal, which is a very, very, very popular diet tracking app. It's the top diet one, but it's also, if you think about all the apps in the App Store, so millions, it's in the top 100. I looked just the other day, it was like number 88. So it's clearly very popular, but the question is whether or not it's actually helpful for people. And like I mentioned already, could we have broader reach? Could we approach obesity treatment for weight loss with a lower cost? Thinking about cost, because that's really, really important. It's not just about can you get people to lose weight and keep it off, but like if it's so costly, health centers aren't going to adopt it. It's not going to be something that can be disseminated. But maybe if we use some of these approaches, it's more likely to be. And again, there's not much time to talk about this, but in our center we do work on how to incorporate these technology-based interventions in primary care, particularly for some of the folks in the community health center networks in North Carolina. Okay, so here's just a global look, and I don't think this is really exhaustive, as we were talking about yesterday. Like India, for example, is not on this list, but here's some of the Pew research data again. So again, cell phone ownership is incredibly high. And it's really high in a country like China, and you'll see where we applied something to that country. But smartphone usage is not as high, but it's on the rise. And like in the US, most people are using cell phones globally for text messaging. That's really the thing. And only about, I think it was the median usage prevalence, I guess however you call it, is about 78%, and only about 15% of these are being used for health information. So, text messaging for a variety of things may be a great modality. But what types of digital health devices are most studied, and how do they seem to fare in the literature? And in the U.S. literature on weight loss trials, we see the web-based trials are dominating. And we believe that is just because of publication lag. That people are starting out doing web-based approaches to weight loss. When I say web-based, I mean either using email or having a tracker on the web, right? But as I mentioned, maybe they're missing an opportunity to reach a lot of people. And we don't know that much about things like smartphones or apps, certainly apps, but even text messaging. But more and more people are coming out. Of course, it's a lot of pilot trials because we're still, the bigger trials are not yet released, as industry has already surpassed all of us in research. But and there's a lot of heterogeneity here. So some people take your standard approach, replace the self-monitoring with a web-based, right? Or they try to deliver things through emails instead of face-to-face. So, but generally, on average, these approaches are producing less weight loss. So about half the weight losses we're seeing from the standard approach. Now you might be like, oh, that's a bummer because we want to, this has more potential. But you think about if you can get a small amount of people who are very selective to lose a lot of weight, or you can get a lot of people to lose a smaller amount of weight, we might be better off as a result of that. Okay, so let me stop there for a second in questions before jumping into just going and talking about a couple of trials that we've done in our group. Yeah.
When you just said the standard weight loss, you're referring to like face-to-face?
Mm-hmm. Yes.
So is that the consistent, like it's only about half, like they're losing much less weight? Because I've read certain studies that actually show a much closer percentage between smart apps and face-to-face versus things like paper-based or not. Right.
There's so much heterogeneity. So actually a paper I just read yesterday swapped out the self-monitoring for an app, right, where they give a lot of feedback in the app, but they also had the face-to-face individual group sessions, the whole thing, except for that was the only thing. And the weight losses were comparable. They were like 8%. They were really high. And that was very exciting. It was a pilot study, and I know that group actually has now a larger R01 happening. But so I think that's where the heterogeneity is. But see, to me, this is where I lean on this side, is that approach is it's still not getting at what we really, and it's helpful, right? But that means it's still a selective population who can still engage in the other components of that intervention. Do you know what I mean? Mm-hmm. Things that we're interested in is if people come into the health center, could you then sign them up for like a totally remote technology-based intervention? Maybe you don't get 8%, maybe you get 4%, but you get weight loss. Does that make sense? Yeah. Okay, so what I'm going to talk about today and give you a little background is an approach that was coined by Gary Bennett, who's the head of our leader in our center, called the interactive obesity treatment approach. And I'm showing you this because two of the studies that were used text messaging, that was the approach. And what this approach does is try to get away from your standard self-monitoring through paper. It's using digital health, but making it easier to self-monitor, so you're not having to just even still include an app and figure out every food that you eat. So let's revisit this one more time. So to gain weight, you have to eat more than you expend. This is the concept of calorie balance. And obviously to lose weight, you have to take in and expend more. It's simple in that concept, but of course it's harder once you actually apply it. Side note that we know mostly the way to lose weight is by changing your diet, and exercise is great, but it's not going to give you as big of a benefit as diet. Once you lose it, you're going to need exercise to keep it off. But so it's not 50-50 is what I'm trying to say, but they both play a role. Okay, so IOTA, or as we affectionately call it, is what it does is it surveys people on how they're doing with their diet and exercise. So ask them a variety of questions. So this is a web-based survey, it could be, or on a tablet or anything. Ask them how they're doing with specific diet and exercise goals. So how many sugary drinks do you normally drink in a week? And it's gotten more sophisticated as we've done probably it's like the 5th or 6th or 7th trial using this. But basically what it's trying to do is get you away from tracking calories, fat, minutes of exercise, and rather tracking concrete, simple behavioral goals that will help you tip this towards what we call a calorie deficit, towards weight loss. So if you're someone who drinks a lot of sugary drinks, so like soda, juice, coffee drinks, all that kind of flavored coffee drinks, if we tell you to stop drinking that, you could be tipping and saving like 200, 300, 500 calories depending on how much. So the cool thing about this is that it asks people all these questions. On the back end, we do like a computer runs an algorithm and then spits back to you what 3 goals that you were most relevant to you. So if you don't drink soda, I'm not going to tell you to stop drinking drinks. It's not going to do anything for you. But if you eat a lot of fast food, we're going to tell you to cut back on that. So it's very highly personalized in that regard. So here are just some examples, but we have an extensive library, and like I mentioned, with every trial it gets bigger, and we're realizing more and more which ones are most, we're trying to look at which ones are most effective and for helping people lose weight. Does that make sense? So if you have questions about IOTA, you can ask us, but I wanted to give you that before talking about how we apply this to text messaging. Okay, so this study is called the Shape Plan Trial. And I'll show you a classic of our text message, but it was really low intensity, right? So no face-to-face counseling, not trying to bring people in and do this intensive approach. We asked them to track 3 behavioral goals every day based on this algorithm, like I mentioned, through text message. So here's what it looks like. You get a text message every day at 8 a.m. Please, it was 8 a.m.? Mm-hmm. 8 a.m.? Mm-hmm. Erica spearheaded this. I should give her that, definitely, to let you guys know that. Number of steps or sugary drinks or TV or whatever your 3 goals were, and then we asked you to respond with feedback right away and in a very simple way. And people caught on to it pretty quickly, but each person got a pedometer. They also got lots of materials about how to change these things, because it's the monitoring, it's feedback, and it's we call it skills training, but it's basically understanding educational materials around it, about how to change your diet and exercise. And then immediately they got some kind of feedback, and we kind of operationalized this as a score, so the higher the score is better, so people knew they wanted to get closer to 10. And then it gave a feedback relative to yesterday. So today you're a 7, which was better than yesterday. Keep up the good work. Here's a quick tip to help you reduce the sugary drinks. And you might think, oh, they had 2 sugary drinks. That seems like they should have 0, but 2 is better than whatever they did yesterday, so they're making improvement. So this was it. I mean, we initially had them come in just to give them an orientation, but there was nothing else besides this. It was all through text message, and they had the materials, and just wanted to see what would happen. And additionally, this population was predominantly lower income Black women, so I think it was like 88% were Black women. So this was, we're also trying to target, like I mentioned, those who are most in need. Yeah.
Who did you select for that subject group? The income or the ethnicity or?
The goal was originally to have it be 100% Black women, because again, that's like, so, but then, we can talk about that also, like issues with recruitment. We ended up opening it up a little bit more. So that was really the main goal, was that. So this is a spin-off of a trial called SHAPE, which was Gary Bennett ran a big R1 that was looking at weight gain prevention in Black women and using some other technologies, also having some coaching, so it's a little bit different, but again, we really see a need there, so that's what I was focused here. Okay, so what we found is interesting. This is the adherence to daily text messaging. So unfortunately, we're still seeing this decline, although it's a little bit better than paper-based, about 49% adherence rate. And what I mean by that is that, each week, 49% of people monitored this every day, right? So like this is, every day they got these texts and they responded quickly. It was a pilot study, a very selective population in some ways. So we made some improvements over your paper-based, but clearly we would like it to be, again, more stabilized. And as a result of just this text messaging approach, the women lost about 1.25 kilos, so that's about 3 pounds if you think about over a 6-month period. But the control group, was a delayed control, so this is a randomized trial, they gained about the same. So showing promise, this is a short-term, small sample, showing that, and very low intensity approach. So again, there might be lower weight losses, but there's a place for that. So we wanted, oh yeah.
Sorry, which months were these over? Was it like holiday months or was it summer months?
Good question. It was in 2010.
Yeah, it was the middle to the end of 2010, so it was before the holidays.
But I think there was some overlap with the holidays in terms of the 6-month visit. Now that yeah. So that's an issue too. Like so many people might do cohorts, and then you have the seasonal thing that can wash out. But we didn't have that opportunity here. Yeah. Good question.
What was the experience for the control group?
Yeah. They actually, they had no intervention during the 6-month period. Well, they should say no. They came in initially, we gave them a kind of basic group thing, or individual, depending on which they couldn't make, on like healthy lifestyle eating. Erica, add to that if you want to. But it was delayed, so they got it at the end. They received the text messaging program at the end of the 6-month period. So like that was a way for us, we wanted to make sure they get something, but we needed to know compared to nothing if it worked. Yeah, you want to add to that?
Yeah, so we used a pretty standard, what we call like a health education control.
Yeah.
So the women who came into the group sessions, once they were randomized, the control group got health education session, like an hour-long, kind of like, this is, you should eat more fruits and vegetables, you should exercise, this is how we prevent weight loss or weight gain and that kind of stuff. But then the difference really was that in the intervention group, we focused our education on behavior change. So these are the steps that you can take to change this behavior. We did some, we like worked with them on creating an action plan, that kind of thing. So they both got attention, and they both got kind of education, but one was more focused on behavior.
Right.
Did the control group get a pedometer during their control period?
No,
Question.
they
Yeah.
did not.
I did not. So I guess the isolation here is the text messaging and the pedometer. Yeah, because actually, Erica, you bring up a good point, because they did get some, oh boy, here we go. Okay. They did get some of these other things, like they got, like you mentioned, some healthy, but then also, like, they got a DVD, they got some things, so we were trying to isolate the text messaging, and in this case also the pedometer, which was tied to the, the self-monitoring. Yeah, so they did get some in that regard, so yeah. Allows for really better isolation, understanding of the isolated effect of the text messaging. Someone else have a question over here? Am I? Okay. So then we wanted to see if this could be applied globally. So again, Erica spearheaded this one as well. Was to, she likes text messaging. To see, again, just want to show you again, just to remind you that, particularly in China, there's a huge uptake of mobile phone subscriptions, and I mentioned text messaging is the number one function that people are using with these phones. So the question was, can you apply what we learned in Shape Plan and apply it to a group of adults in Beijing who are looking to lose weight? So it was a partnership with Peking University. Same approach though, this IOTA approach, where people had all these goals, and they're asked to again, tailored to them through the algorithm, asked slightly different goals that were more relevant to individuals living in Beijing. Asked them to self-monitor it, provide them the same kind of skills training materials, except in this case, there was a little bit more face-to-face. Because maybe, we talk about this all the time, maybe you need some face-to-face or some coaching. It could be phone, it could be face-to-face. Maybe it's not just enough to do text, and how much more do you get if you add that in? So a very similar thing here. So here's an example of the text look like. This was another study, it was a spin-off called Adapt that we did, but basically the same thing, asking them to, try steps and other things, other goals, and giving them feedback. This is exactly what it looked like. So the results are a little bit more promising, particularly when it comes to adherence, and I apologize, this slide is a little bit hard to read, but this paper just came out if you're interested in seeing how it did this in obesity. And so you can see this is looking at two groups, those who lost greater than 8.8 kilos, so like about 2 pounds, versus those who did not. And you see, there's still a decline, but overall, not counting for weight change, there's about 68% adherence rate to this daily text message. So maybe all these other things helped improve it, or maybe it's just more relevant to this population or whatnot. So when it comes to weight, seeing a similar picture here, so they lost about 1.5 kilos, which again, was clinic. But the great thing about this is it seems small, but it's significant between groups over 6 months. But that these results were clinically meaningful in this population. That I think we were most excited about is that we saw drastic reductions in systolic blood pressure and diastolic blood pressure. And high blood pressure is on the rise as well, and other, not just in the U.S. So I think what's really interesting is that with just small amount of weight loss, you're seeing these clinical benefit. It doesn't have to be 50 pounds. It can be 1.5 kilos. And hopefully, if people kept doing this text messaging tracking, imagine we had an automated computer that just did it every day for them for years, that would keep going down. Any questions about that? And I should give you some, just sort of give you context here. There's other studies that certainly have used text messaging in these more lighter touch, lower intensity, and they're usually getting about 2 to 3 kilograms. We're not talking again, but I mean, if you add coaching or if you do a standard approach where you still see people face to face, you might be able to get more. And we're testing that now a little bit with a hybrid approach of a lot of different things. So, we'll see if we're thinking we're going to get bigger weight losses this time. Any questions on text messaging? I'm totally going to jump in a different direction. Yeah.
Just really quick, has there been any sort of research done on doing face-to-face to start out with and then trying to continue weight loss through mobile interventions then to kind of continue it? I'm sure they'll gain some, but then plateau out? Has that been shown to work?
That's a really great question. I know that there are a few trials in the field right now that are looking at that for a variety of outcomes. So some are looking at weight gain prevention, So, which I think is also an important way of addressing obesity, right? Like people are younger, 18 to 35, and then, but that's a really good question. And my understanding of literature is that no one's really tried to really do that. I mean, I think they'll have phone or follow-ups and things, but whether it's this consistent text messaging after receiving an intensive program, I don't know if we know that answer. It's a good question. Yeah.
Sorry if you said this already, but is the text message that they're receiving from a person, or is it automated based on the response?
That's great, because it's all automated. So the computer system sends it out. I mean, we can get into the weeds there on it, but there are a lot of software out there that can just do it for you. You don't have to actually do it. And I think that's the beauty of it, is that there was no human interaction with that, with both of those studies, except for in the China one, we did have some face-to-face. Yeah.
Do you measure how motivated these people were to lose weight? Like, were they interested in it, or were they just kind of enrolled in?
Yeah.
'Cause that's a real obstacle. They start out not motivated.
Yeah.
Any weight loss is great.
Right.
We
Usually, it's a great question, because we usually people who sign up for weight loss or more
Okay.
are more motivated.
So there's some motivation there.
Yeah. So in Shape Plan, I would argue that those women were less motivated than say other groups.
Yeah.
Not to get into the weeds on that, but just generally, we know there's less of a motivation for weight loss in Black women for other reasons, sociocultural norms and whatnot. But we don't actually have any really great measures of motivation when it comes to this. It's actually kind of amazing. But we always infer, and we don't actually know what people who come in, like who's going to be most likely to do well. We have no real sense of that. We collect so many variables, but we don't actually know what's most predictive of success at the end. We're starting to see some, but I would argue in the populations that we did, they're less motivated than say some of the standard people who signed up for that intensive standard approach. Yeah, but motivation wanes really fast.
Yeah.
People start. That's why that motivation, particularly to track your diet, that goes down really quickly. Yeah.
I just wanted to respond to the question about the studies looking at face-to-face followed by a text intervention. We're actually going to be starting, I'm Christine from the Duke Diet and Fitness Center.
Great.
We're going to be starting a study really soon with Ryan Shaw.
Yes,
in nursing.
yes.
And we have a residential style obesity treatment program, so they're going to be working with both new and return clients in our program that go through a period of time as an intensive program, and then following up with text messaging to see how they do.
Yep.
So it's just starting. Look for that in the near future, actually.
I'm glad you said that. Ryan and I actually have talked about it, because he was thinking about ways we could work together to look at the data. I think that's really, 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 really important, and an easy way, to automate it and follow up.
Right.
Awesome. Yeah.
Quick question. I'm interested in child health, and the numbers are really striking there.
Yeah.
Have you guys thought about asking questions about their children consumption of sugary drinks or watching television?
Yeah, that's a great question. We haven't thought about in this trial, but we literally the last month or so, I have been trying to hook up with people who do some childhood obesity treatment here, working to see if we can do slightly different, we were saying, but intervene with these approaches, text messaging, the IOTA thing, with the parents, and seeing if that trickles down to the kids, because there's more and more stuff coming out that there's sort of this collateral effect on the kids, and that you don't actually, do you have to treat both? I mean, this is not my area, that's just so that I know, but we were trying to get into that, because I think it's clearly important, but that would have been interesting if we had collected that data on if they know their kids' food consumption. Yeah, it's really interesting.
Can I just add
Yeah.
to that? So we have a trial in the field now that does use phone coaching, as well as automated self-monitoring for behavior. And anecdotally, from the trials that we've run that have used coaching, we've heard that for mothers specifically, but I think for parents in general, once they start changing their behavior, it's easier for them to help their kids change behavior. And their kids kind of, it's a struggle at the beginning, and then their kids kind of get used to it.
Yeah.
Have you...
Yeah, it's interesting. I think it's I think if you intervene, like you said, intervene with the parent or intervene with, and they change the food environment in the house, and it trickles down. Yeah, I mean, I think it would be interesting to collect actual data, but I hear that that's also difficult, right? Because it's the child's not giving you the data, the parent is, and you don't know if they're at, they're at preschool or daycare, what they're exactly eating. Yeah.
I have a question. It's interesting that you presented the health interventions actually happening in China as well.
Mm-hmm.
And I was wondering if you see there's a difference in terms of implementing the strategy in China, because there may be different risk factors in China. Instead of drinking soda as a question, people may more under like smoking or alcohol strategy, which are also the risk factor for diabetes. So I was just wondering, when you're implementing this strategy in China, is there like a difference?
Yeah. Can I let you answer that, because you're pivotal. Erica's my co-presenter here today, because she was, obviously implementing that and talking with them. Because I think there was a lot of formative work, I believe, or some formative work that went into it.
Yeah, so we ran focus groups because we had a good a set of landscape in the U.S., but we knew that China would be very different, and the barriers would be different. And what was interesting about Beijing specifically was that we found that it was very, very easy for people to reach the 10,000 step goal. Part of that was because it's just urban, right? Yeah, and it's more comfortable to walk. There are like more sidewalks and stuff. But people didn't really have a problem with that so much. But drinking was a much bigger problem, especially for the men that we enrolled, because it's very cultural. It's like connected to work in a different way, right? It's cultural. Drinking alcohol. Yeah, sorry, alcohol. Yeah. We didn't really focus on smoking. That wasn't like really the kind of goal for our specific intervention, although maybe with these results that maybe it's had effect on other behaviors. Yeah, exactly. But yeah, we ended up kind of doing getting a sense for the landscape of where people could kind of get food, what kinds of food were available. So one of the goals was instead of no fast food, it was no Western style fast food. Instead of no chips, cookies, or candy, it was like no street snacks or packaged food. And then sugary drinks was also like teas and kind of those kinds of things that you could get very quickly in a convenience store. So we tried to kind of adapt the goals to match the population. Yeah.
Thanks.
Yeah. In your background research, have you come across any studies that have replaced face-to-face counseling or communication time with AI or character-based AI? So not just a text, but a figure that says, "Hey, you're great," or supplies that sort of information.
Yeah, there's a whole field of I think it's called human-computer interaction. It's a whole field. I've looked into that. I think it's pretty nascent. It's not really, particularly in terms of intervention trials, looking at it.
It's more common in apps today. That's why I was curious if it's been researched yet.
I think I'm not as familiar with it, so I shouldn't really answer, but I know it's used in medication adherence and things, but I don't think we've seen as much applied here. I thought you were going to go down the route of video counseling, because that's something which we actually don't know much about, and
it's similar. It's a similar question, but video counseling obviously requires more time commitment from the person that's providing the counseling, whereas this is just a face that's still hooked up to a computer.
Yeah, I think that's great. I think that's one of the future opportunities that can happen in this area. So I wonder if it's so text messaging did help improve it a little bit, some tracking of diet and exercise. But maybe it's just the fact that we're asking people to track diet and exercise that's just so hard, right? We know it works, but are there other things that you can track that are easier? And this is really getting into something that it's very near and dear to my heart. Back in 2006, I've known Gary Bennett for a while, and we talked about, what if you just asked people to weigh every day as a way of tracking, and not, this is pivoting a little bit, right? And not ask them to track diet or exercise at all. Because there was emerging evidence then, and we've had more and more show that that's an incredibly effective self-monitoring. People who weigh daily lose more weight than weekly, and it's very linear. So we did a study to look at this. And we used, we call coin smart scales. Essentially, they are scales that look like anything else, any other scale, but they send your weight through the cellular network like a text message. So you step on the scale, it sends the weight. It's remotely connected. As researchers or interventionists, we could see people's weight, and they knew we could see their weight. It's also sent to a site where they could look at a graph of their trends over time. So this was called the Weigh trial, randomized trial, where we asked people to weigh every day. And we used data on how often they were weighing, were they adhering to it, and were they losing weight, to give them feedback each week through email, not text, through email here. And for a variety of reasons for this, I think, we just really were interested in the weighing, but also recognizing that, again, feedback is important. These behavior change lessons or skills, through, we sent them in the emails as PDFs, are really, really important as well. But I want to emphasize again, to keep the intensity low. It wasn't like I was writing, 100 emails. This was 100 people were in this trial, of which half were in the intervention arm. I wasn't writing 50 emails each week. And what we were doing is that it was an algorithm that if you weighed daily and you lost a certain amount of weight, you were all collapsed into one group. And if you weighed daily but you weren't losing weight, you were in a different group, and similarly, if you weren't weighing daily and you weren't losing, you got a different. So each of those people in those groups got, so only 4 emails that went out each week. You know, it's just that it was slightly tailored to the person. So we, you know, would say, "Dear Joe, you've lost 6.2 pounds, you know, you weighed 6 days." So like those numbers were unique to the individual because we had all that data. Does that make sense? Okay. And it was key thing here is there was no mention of diet or exercise. Actually, it was like discouraging you. Don't engage in that. And a few people did on their own, but it wasn't encouraged for sure. And then the control arm received no intervention, was delayed intervention again, a 6-month trial. But we did give them the scales because we wanted to have an objective measure of if they actually weighed. So, but told them if you don't weigh, take the scale and put it under your bed, hide it. You're not going to use it for 6 months until you get this program. But if you do weigh, you know, once a day, once a week, once a month, use our scale instead. So we really had an objective measure. Alyssa, did you have any?
Yeah, I'm curious, were they instructed to do, like, weigh at the same time every day, or weigh with no shoes? Or?
Yes. So there was a lot of instruction in the beginning about, you know, use the scale as a tool. It's not a value of yourself. It's not a reflection of yourself. It's just a tool to help you understand how you're doing with your eating and exercise behaviors and make changes accordingly. So if you see your weight up one day, it could be just a fluctuation, or it could be because you had a buffet dinner the night before. You know, recognize that connection. And a lot of people did. They realized when they went out to eat or when they, say, ate a snack, like not even mindlessly eating while they're eating, you know, watching TV, that their weight was always up. And when they cut that out, it went down. But we did tell them first thing in the morning, no clothes, like, you know, to get the real true reflection of their body weight, not any other extraneous things. Because you can drink a whole bottle of water and gain 4 pounds. That's if you wait immediately. We've done this. Okay, but again, lower intensity, but a different population. You know, this was a population of higher educated, higher income folks, predominantly, you know, 75% white in the, you know, Chapel Hill, Durham area. But again, you know, we had a different agenda here. Agenda is a strong word, but you know, the goal was to really just look at this, and then we're actually, I'll show you results using this approach of daily weighing and these scales in our trial now with the lower income folks in community health centers here. So it's not that we think it's just for this, but so we're applying it there as well. What we found was amazing, I think. After 6 months, those in the intervention arm lost about 6.5% of their initial body weight. So again, really comparable to the diabetes prevention program I showed you, right? And the control group, they stayed the same. There was no change over time. So there's almost 7% weight loss difference between these groups. And what I'm most excited about is when you ask people to weigh every day, they actually do it. So instead of seeing that decline over time, we saw people were hovering each week, this is 23, 24 weeks of intervention, anywhere between the 6 and the 7 days per week that they're weighing. So they were doing it. And as such, likely was a big contributor to why we saw the weight loss, that they were consistent with their self-monitoring. Weighing every day is very easy compared to tracking diet every day, right? And then as a side note, because I'm always interested in like, can you just weigh once a week, or you know, that these people in the control on their own were weighing once a week, which you know is very much so talked about as a common thing. Like, don't weigh yourself more than once a week, you'll go crazy, you have fluctuations. But if you just tell people to weigh every day, once a week without anything else, they don't lose any weight. It has to be something where maybe daily is more effective if you give them an intervention as well with feedback and skills training. Any questions on that? Because I think, you know, we were excited about those results, suggesting that, you know, a mobile scale, not a text messaging, where people weigh every day in a low intensity intervention was effective.
It's more a comment than a question. I think it's interesting that you say that you began the program partly by trying to educate them that the stepping on the scale is not a reflection of self-worth, when clearly I would think that potentially this is slightly biased by the fact that they know you're looking at their numbers. I mean, certainly this population is probably not a population that likes to get weighed at the doctor's office either. So just the fact that you're looking at it every day is a difference from me stepping on the scale and nobody sees it but me.
Totally, yes. That passive, I should have mentioned that passive accountability, I call it, like where you're not doing anything to them, not talking to them, but the fact that they
But you're judging me by what my stepping.
I think, and this is all anecdotal because I didn't, but I think judging, I don't think people felt that it was judgment because they said to me, knowing you were there was a factor, but a lot of people, it was all anecdotal when, I would just talk to them, was more of, that it really was a helpful tool for them. And some people, who knows, they said, oh, I forgot you were watching, but I doubt that. I think it was a really helpful tool. I just heard so many examples of people making amazing changes just because they realized it was not helping them see the number go down. And I know this is a little controversial, and clearly in the lay public, people say throw your scale out the window, right? Don't even weigh at all. But more and more evidence is showing that this could be really effective when it's framed properly, right? I don't know if it's effective for normal weight college, women, for example. I just know in these overweight and obese adults who were seeking weight loss treatment, this was a helpful tool. Yeah.
Was there any checks in place to see whether they actually read through the entire email that you sent them to know whether it was actually just seeing their weight every single day affecting it, or whether they were actually implementing any of the suggestions you were sending every week?
It's a really good question, and unfortunately, this was again a pilot study, and we've learned a lot too. We actually have software we use now where we can send emails and track if they're opened or not.
Like how long they're opened or something. Yeah.
And if, we don't know exactly how many information they're absorbing, but we didn't do that here. They each had a login to a website where they could see their graph, and so we saw that the more people who logged in, they did better. So it's just another indicator of motivation. But I don't know that. I wish I did. Okay, let me jump ahead quickly here. So because I really think apps are really a big thing now. So obviously I mentioned there's lots of apps out there. Lose It, MyFitnessPal, Nike, Weight Watchers, they supposedly help make it easier to track your diet. And sounds like maybe some of you have tried these apps, that you don't have to look up everything you're eating and the calories, you just enter it in the app and it does it for you. So there's less math. You still have to enter your food though, you still have to do it. And the crazy thing is that, this is this is also incredibly popular and in some ways ubiquitous, and I shouldn't say ubiquitous, but there's a lot of popularity of these, but we have very, very, very limited evidence to know if they actually work. We don't know if they're better than, some things are starting to come out if they're better, but and when I say these, these are commercial apps, right? Not an app that I create as a researcher, which people are doing, but do these commercial apps work? And are they even based on evidence when, we don't have people who know the evidence designing them? And so some people, actually a group here, looked at sort of a content analysis of these, and some other group did this as well. And these are sort of your basic strategies that you should be talking about when helping people lose weight. And the apps that they looked at, the top apps, none of them included all of these. And only 10% of all apps in diet that they reviewed included 6 of these. So indicating that there's very limited actual evidence-based strategies implemented into these apps. MyFitnessPal, for example, only included 15% of evidence-based strategies. So very popular, being used by a lot of people, but isn't actually helping people to change their diet. And I know that there are probably examples here where people who use them and it's incredibly helpful. We would like to know if they're actually, test them in a real trial. So we're looking to do this, test these commercial apps and see if they're effective. And of course you have your wearables. Who's actually wearing a Fitbit right now? All right, we got one.
It's not a Fitbit, but yeah.
Something like Fitbit, yeah, okay, Fitbit being most popular. So, again, these give you a lot of data on your steps, more than a pedometer. They give you calories expended, they give you miles walked, and so on. But is that more data helpful? Do people continue to wear them? Do they actually help you improve your activity? I think anecdotally, we hear people stop, just like they stop using the apps, they stop wearing these things as well.
Eric Finkelstein did a study on them in Singapore.
In Singapore?
You should talk with Eric.
Okay.
He's very interested in these. It's the same 3 months.
Right. It stopped at 3 months? Yeah, it's so interesting because it's these are out there, so again, I just want to tell you, we're trying to get people to go from here to challenge to go from here, but we don't actually know if people will wear these things. So briefly in our last few minutes, I'll tell you just about a study I did with Ryan Shaw, who's at the nursing school. He spearheaded this called the Mobile Health Platform. Basically, just wanting to see if you tell people to wear multiple devices for just 1 month, this was a really, really preliminary feasibility trial. If you tell them to wear it 1 month, will they do it? And in this case, we wanted to see if we could collect multiple data from multiple devices simultaneously. So not just the text, not just the app, not just the scale, but all at once. So we gave everyone a Fitbit wristband. I know that's not that activity tracker there. We gave them the Fitbit app that came with it and asked them to track their diet on that every day. We gave them wireless scale, not the one I showed you, because this one just used the Wi-Fi network, but the same thing where it remotely sends it. Also a blood pressure cuff. And also, not the glucometer, because at the time the FDA didn't approve it yet. Now it's approved. But so essentially the same thing, plugs into your iPhone or wirelessly transmits your glucose. And they give a pulse ox to measure pulse ox. So same thing, a wireless pulse oximeter. So again, just will they do it? Not any other intervention. This was feasibility, just to see will people do it, just for a month. And this was an N of 6. Okay, so all that aside. We found that, so this is what we found. We found that most people, this is percent of days, so you have 30 days in a month, and you have on average, people wear the Fitbit 71% of days, so not bad, considering. They use the blood pressure cuff daily, only 49% of days. The weight, unfortunately, based on what I just showed you, they only did it for 45% of days. Diet less than that, 40%, 41%. Sleep was less, and I don't know who ever used the Fitbit, but sleep is just like having a stopwatch on your Fitbit, right? It's like, I wish it would just automatically know you're going to sleep, but you have to start and stop it, so it's more effort required. And then the pulse, and I think this was because this was the least, because it was the least relevant. Half of these people had a comorbid condition with obesity, so high blood pressure, diabetes, and half didn't, just as a way of seeing if there were differences. So interestingly, it suggests that maybe people will, but maybe they'll wear the Fitbit, but it seems like you need some other intervention if you're going to get people to really adhere to using these, and they're very emerging, but whether or not people, again, we want to get people to consistently engage and wear these things to self-monitor. Okay, so future studies. Do apps plus feedback work? Do wearables work? Do you need to give feedback? We're thinking about doing a couple of pilot trials where we just tell people to track through MyFitnessPal or wear a Fitbit and see if it does anything. Video counseling, like I mentioned, could that be a way of emulating a face-to-face encounter easily? Especially as Erica reminded me a couple weeks ago that if more and more towns have free Wi-Fi, can you use that? And then again, more translation to some global settings. It'd be interesting to check out Eric's study there as well. So I know that was a lot. It was an overview, so I know we have a few more minutes. I'm happy to stick around too, but if you have any questions, or if you're, like I said, we're doing a lot of these things, so if your students have any interest in working with us, there's a lot of opportunity there, and you can check us out and get some info. So thank you guys.